Okay, thank you very much indeed, everyone, and welcome to the Performance and Audit Committee of the 24th of September 2025. Before I go on to apologies for absence, I'd like to apologise for the large agenda that you have today and the large amount of detail you've had to read through today. It's a matter I'll take up with the Chief Officer and the Chief Finance Officer, but it's quite an excessive amount of information you've had taken today, so I do apologise for that. That takes me on to another matter. Arlene's not feeling well today, but she's womanfully agreed to stay on to support us, but she's going to stay off screen, but she will do the normal roll call. Arlene, do you want to do that first?
I will do, Chair. Thanks very much. So Bob Benson.
Present.
Councillor McHugh.
Present.
Councillor Toland. I've had apologies from David Cheap, and Colleen Carrollton is present on his behalf. Dave Berry.
Present, Arlene.
Christine Jones.
Present.
Sanjay Pillai.
Present.
I've had apologies from Glyn Lloyd. I've also had apologies from Jocelyn Lyle, but I'm not sure if there's anybody here on her behalf.
Yeah, Barry Hudson's here.
Oh, thanks, Barry. Raymond Marshall. No. And Martin Sloan. No. Okay, Chair, that concludes the roll call.
Thank you so much indeed, Arlene. Item, our apologies for absence. Any absences formally noted, Arlene?
Yeah, these have been noted. Thank you.
Okay. Item 2, any declarations of interest relating to today's agenda? Thank you. And that takes us on to the item 3, the minute of the previous meeting and the action tracker. Can we therefore go to the minute, and can I ask then we'll comment on the accuracy of the minute before I move to approve? Are we content with the accuracy of the minute then? I take it that's
yes.
A yes. Thank you. Thank you, Dorothy. And I'm now going to formally approve the minute correspondingly. Okay, the minute is now approved. That then takes me to 3V, the action tracker on page 7. So who wants to take me through this item?
I could do that if it's helpful. So it's been fully updated since the last meeting. Just to note, in addition to the information, that their items 4 and 5 has since been completed this week in terms of provision of information to Councillor McHugh. But obviously happy to take any questions, Bob, from members.
Thanks very much. Questions? Dorothy.
Thanks, Bob. Catherine, you might be able to answer this, or someone else, hopefully. Item 3, issues in relation to disengagement. It's the status comment that I don't really understand. Data quality and intelligence team and operational managers to discuss revision of a disengagement indicator, as this is now no longer being utilised. What does that mean?
So Lindsay basically is working with Russell Goldsmith, who is the person who leads on drug and alcohol reporting for DDARS and also for the Alcohol and Drug Partnership, to look at that disengagement indicator. I think it's reported at the moment from Daisy, but there's a number of partnerships areas that have stopped using the indicator because there's concerns about its kind of methodology and the underlying data quality around it. And I know, obviously, Dorothy, from our emails over the last few days, there's lots of different aspects around disengagement and what the data's telling you. So I think they're keen to have a look at that and make sure that they're using an indicator which gives you a more accurate picture of what disengagement looks like. And as normal, that might not be a single indicator, it might be more than one. So Russell gave us a bit of an update, but I'm sure, Dorothy, if you wanted any more information about that, Russell Goldsmith would be happy to speak to you off table, as would Lindsay. But I think what you can expect is that that indicator might be removed and replaced by something different around disengagement in due course.
Okay, that was my concern, that it was just going to disappear and there wouldn't be anything in its place. Right, okay, thanks, Catherine.
Further questions on the tracker? I was just going to ask a general point, and I was looking at item number 1, and I note that this originated in September 2024, and I begin to wonder about the relevance of that, given that we are given regular quarterly reports anyway, that these questions could be incorporated into those quarterly reports. I don't know what the response would be to that. And I wondered whether item 3 should be archived, as indeed its relevance now. So I think there are issues where we've got some stuff that's sitting here for rather a long time. And I just wondered, given that we're getting regular quarterly reporting, whether these can't be incorporated into the updated quarterly reports.
Yeah, obviously for item 1, that sits in my area of the service. I'm happy to look at that. I think you're right, Bob, and as the update reflects, yourselves were looking, or Lindsay certainly was wanting to look at whether actually the issue that had come up around the West End was actually still relevant before we do any further analytical work because of the passage of time. So Lindsay's picked up on the same issue and it wants to come in. Lindsay.
Great, thank
Lindsay.
you. Yeah, actually, looking at more recent data, there isn't the same significant trend within the West End. So it has corrected itself, and the quarterly performance report is on the agenda, so we could look specifically at West End when we get to the Q4 performance report. But it's not such a significant issue as it was when it was first raised last year.
If that's it, thank you very much, Lindsay and Catherine. So can we conclude, therefore, that this item should be archived, given that it's now been superseded by further reports then? Would that be a logical outcome of this discussion?
I would say so, but I see Dorothy's got her hand up. Will Dorothy want to come in?
Yes, Dorothy,
Yeah.
Yes, I appreciate that. Dorothy.
I just want to say, it's probably one of the people who raised this originally in September 2024. I'd be quite happy for this to be archived since it's overtaken by events, really.
Thank you, Dorothy. So therefore, with item 1, we can now archive this and remove it from the tracker, and we'll incorporate it into future reporting. And item 3, I think I had much the same question on that as well, because I think that we could keep on looking at data as a separate issue all the time, and yet we're still getting quarterly reporting. And I just wondered if we could take this one away and then just give me some feedback on how we progress some of these trackers. Otherwise, they're just going to stay there for an inordinately long time when they're already superseded by more frequent quarterly reports, quite frankly. David, you have a view on that?
Yeah, so I think in relation to item 3, I think we've kind of got from the kind of previous question, we've got a bit of a kind of response on that one. But I think, yeah, happy to kind of look at any other ones that relate specifically to reporting, where the next update could kind of feasibly can include an update on the question that's been raised. So
well, indeed, because they will, internal audit will only want to look at these and ask, why is it taking so long for these items to be addressed? And I think that's something that, given that they appear to be unnecessary to me, and I think we can deal with that ourselves. So in terms of item 3, I'd like that to be archived as well, if we can agree to that on that same reasoning. Can we therefore agree that? I'll take that as a yes. Thank you. Are there any further questions in relation to the tracker that hasn't been raised so far? And if not, we'll just move on. Thank you. Let's now move to item 4, which is the revised Performance and Audit Committee PAC terms of reference. And that's on page 11.
Yeah, okay, thank you. I'll quickly just take everyone through this one. Just the draft revised terms of reference are presented to PAC for review and consideration, just as a bit of an annual review of these. If these are approved or ratified by PAC members, then they'll be actually submitted to the IGB for full approval before being actually part of the formal documentation. The revised document incorporates some additional duties following the introduction of the global internal audit standards, as well as a couple of amendments and just some minor edits to the existing document. These proposed changes are highlighted in yellow in the appendix document, just for clarity. So yeah, PAC are just asked to review this, confirm that you're comfortable that these are appropriate and sufficient to allow the committee to fulfil its duties. Happy to pick up any comments on the document. If not, we'll take it to IGB next time.
Questions for Christine? One of the questions that's come up for me, Christine, in looking at our terms of reference, and I think I reflected on that at the beginning of the meeting, in terms of the agenda planning itself, which I think is an ongoing issue. I believe that the Performance and Audit Committee should have an annual work plan. It seems to me that the areas of work that we're covering are now getting more and more complex, and it's very difficult to see what needs to be annually reported, what needs to be quarterly reported. And I would like us to consider moving to an annual work plan on this. And perhaps this might help us to plan the work out, and certainly I say as a chair, in terms of planning out what we would expect to see. And with a work plan, we might have to consider, do we have sufficient meetings to cover the level of business that we have? Or are there better ways of doing it? And I'd like some consideration to be given to that. It might be useful to get a view from internal audit as to whether that would be a useful approach as well.
Yes. I'm sorry.
On you go, Barry.
No, it's just saying I completely back you up, Bob. I do feel a work plan would be useful. I can speak within the NHS. What work plans are in place for all your standing committees, and they're reported to obviously every meeting, and they obviously reflect the business that's been covered and what hasn't been covered and what needs to be picked up, etc. I can only comment on one other IGB that I'm involved with, and to be fair, they don't actually have a work plan either. But I do think it'd be good practice. Yeah.
We do have a sort of an internal.
Any comments? Oh, sorry.
Sorry, I was going to say we do have a sort of, as an officer's checklist, we do have an internal document from a work plan. So we can obviously plan ahead, but we can look at how we incorporate that into a formal report to yourselves to actually highlight what's planned and what's cyclical in terms of either annual or quarterly reports and things like that. So we can pull that into a report.
Thanks, Christine. So do we need to adjust the terms of reference accordingly to incorporate that, or does that not need to be required? And I'm going to, that's just an open question at the moment. I'm going to bring in Dave first and then Dorothy.
Yeah, thanks, Bob. So, yeah, a couple of things for me on that. So I think by the very nature of the Performance and Audit Committee itself, if we are to kind of look at all the agendas, they are kind of pretty standard in terms of the kind of the reports that come to each meeting anyway. And there are then the annual reports. So I think we can, as Christian says, we've got that kind of internally anyway, so we can share that with members. I think in terms of the formality of it, I would suggest that we don't kind of have that, include that as part of the sort of formal terms of reference within this. I think there's a risk for us that we then, if it then becomes placed on each of the agendas, it's another document that we then kind of look and scrutinise, and we're talking about having quite a busy agenda. So I think we do that if you would be agreeable, and our members would be agreeable to, that we would maybe do that at our pre-agendas and saying, right, this is what we said we would have, and here's the reports, and any exceptions would then be reported to back to the Performance and Audit Committee rather than cover it as a document. That's just my view on that.
Thanks for that, Dave. Dorothy.
What benefit a work plan would be for the work of the committee. It might be administratively helpful in planning agendas. I'm really hesitant to introduce any more reports, plans, because Bob, you prefaced today's meeting by saying, apologising for the amount of paperwork we've had to go through. So no, I'm not a great fan of that suggestion. I think there is a system in place internally to monitor and plan what comes before us, and I think, well, for me that seems to work quite well, and I'd be really hesitant to introduce more reports coming.
Thanks, Dorothy. Any other comments on this? Right. I hear the kind of there is a degree of difference between folks on this issue. I think, given that, I'm going to suggest that for agenda planning then, which is an informal process, that there is a work plan, that's the same work plan that the officers are using, that enables the chair to plan out meetings. And therefore, on that basis, it does not need to come formally to FAC itself. And I think that gives internal audit some assurance that we're at least working on a plan. But I do think issues are going to become more complex. Dave says they're standard. If anything, I think they're becoming more complex as time goes by. And certainly speaking as a chair, and being in that chair role for a 2-year period, it is very difficult to actually read the expectations that are coming down and to think ahead. And because if the system doesn't work, then we have to think about more meetings and to make it more difficult easier to manage, I should say. So I'm content with that outcome of the discussion. So I would like for the agenda planning to have your work plan that you're working to. That enables me to know what's going to happen throughout our regular planned audit committee meetings. Then I can make a judgment call then as to what may be required and report it back to FAC. Okay, thank you very much for that discussion. Is there anything else that we want to say about the terms of reference before we just move to accept the recommendations? I take it we are accepting the recommendations. Dorothy, do you want to come in?
Sorry, I'm not sure if this is the appropriate place. One of the things I was reflecting on when I was going through the papers yesterday was if the PAC has any concerns about the reports that are presented to it, the phrase "so what" came into my mind. What would we do? You know, if we felt that some of the reports were highlighting serious risks, issues, what would the PAC do? And I looked through the terms of reference and I couldn't really get an answer to that. So maybe somebody could point me to the section in the terms of reference about what recourse does the PAC have if they have these concerns.
I take it, Dorothy, you're talking about escalation.
Yes.
Yeah, I thought that. Dave.
Yeah, that's a very good question, Dorothy. I think for me, and I'm frantically looking at see if it's in actually the terms of reference. The chair's assurance report is to me is the mechanism between taking things from the Performance and Audit Committee to the IGB. So if the chair has concerns about anything in particular, then they can't provide the assurance back to the IGB. So that to me would be the mechanism. But sorry, I'm frantically trying to see if we've actually formalised the chair. Yeah, we do. Yeah, section 9. Chair of the Park will provide assurance report to the next IGB and outline the areas of discussion and decisions. Now that could be tweaked on areas of discussion, decisions, and any concerns, perhaps, if that's something.
Yeah, I did look at the chair's assurance report. I thought that would be the thing, but you know, it's either it's kind of it's given a grading, reasonable. You know, there's 4 gradings and one's given, but that's it. You know, if we get a reasonable assurance, does that mean we do nothing? If it's worse than that, what do we do? I just think that needs to be clarified. What would the PAC then do if they did have concerns? What would be the process for highlighting these concerns to the IGB other than the assurance statement?
And Dave, do you want to come back on that?
Yeah, no, again, I mean, I think I still maintain that I think the assurance report itself. So it would be if PAC members have a concern around a particular issue that's discussed at PAC, then if that's flagged up through the meeting itself, will be reflected in the minute of the PAC, which is obviously taken to the IGB as well. But I think highlighted and re-emphasised through the chair's assurance report itself. So if there's a particular item, that can be flagged out, and then we can have. I mean, we tend not to have a big discussion around the chair's assurance report at IGB, probably because there's not been anything of significant concern that's been escalated. But that, to me, that mechanism still exists through using the chair's assurance report.
Yeah, thanks, Dave. I mean, that is the required route to elevate it up to the IJV itself. And the other thing about that is that the chair has to take the kind of feelings of FAC itself, that there needs to be a strength of view on particular issues. And of course, there are quite a number of issues that are in the paperwork today that might well warrant that within the assurance reporting to the IJV that we might want to strengthen. So I agree with that. With that in mind, Dorothy, I think we've got the mechanism in place to do that. We just need to use it through the assurance report. Okay, in that case, we can now accept the recommendations and can now move on to item 5, which is the annual performance report 24-25. And as you know, this has already been signed off.
Okay.
Dave, do you want to say anything? Oh, sorry, Christine, sorry. Do you want to say something to this report?
I'll let Lindsay pick this one up. I think she's speaking to it.
Excellent, thank you very much. So the annual report was published on the website and submitted to the Scottish Government ahead of the 31st of July statutory deadline. And in order to meet that deadline, it was approved by a core group of IGB members and then thereafter reported for note to the August IGB. So it's on the agenda today for noting. You will have noticed that we've moved back to a PDF flat file version for accessibility reasons. We did move to a SWAY format post-COVID for efficiency reasons, and we hoped that we might be able to meet accessibility requirements in that way, but it just wasn't the functionality there for it. The functionality within a PDF designed version has moved on, though, over the last few years, and we are able to embed hyperlinks, and we have cross-referenced some information and put further information on our website. So by clicking on the link, you can access further information on our website. So the report contains all of the prescribed content, because as you know, the majority of the content in the APR isn't decided by us, it's prescribed in the legislation. So performance against the national health and wellbeing indicators, finance and inspections, for instance. But we always ensure that we align the report to our strategic priorities and report as much information about outcomes for people as information allows us to. So where there's case studies, where there's survey data, feedback quotes, etc., we include as much of that as possible, just to give a sense of how services feel to people. But we also give that balanced view of acknowledging the challenges that we're facing, where we're not performing as well as we would hope, and also the priority areas for future years. So yeah, I hope you found it a good report, but I'm happy to take any questions.
And thanks very much. And I think we also need to know that the IGV did approve this performance report in August. So Dorothy, any questions?
Thanks, Bob. Yes, it's clearly not ideal that this report is published in advance of approval by the IGB. And I was trying to remember, has this happened before? Is this what usually happens? Is it a regular occurrence? Is it an issue of scheduling? Or what makes this happen? First of all, if somebody could tell me, is this the first time this has happened? I should know, but I don't. I can't remember. Has it happened before? And if it has, if this has become the norm, I'm seriously concerned about that. I mean, I know you have to meet deadlines for the Scottish Government, but it's really not good that we're not approving this report in advance of it being submitted.
Yeah, absolutely. I can answer that. This has happened every year that we've published an annual performance report, and it is to do with scheduling of committee meetings. There is a statutory obligation to publish by the 31st of July. Therefore, it has always been agreed that it is approved by a core group of IGB members. So I've written down I've not written down exactly who, but the chair, the vice chair, legal team, chief finance officer, and Catherine will probably come in and remind me of who I've forgotten. But this is just how it has always been. So in order to change that, there would need to be a performance audit committee or IGB in advance. We can't. There's a lot of the annual report that we can't start until the end of the financial year. So in previous years, we've thought, well, let's try and start on it earlier, but there just isn't the evidence to start on it earlier. So we usually start just in the new year, around about January time, and do as much pre-collation as we can. But it really is, we're working quite close to the 31st of July deadline as it is in order to get it published for the 31st of July. So it wouldn't be possible to bring it to an earlier IGB.
Thank you for
I
that.
understand all that, and I'm sure other IGBs will have similar problems. It's still a matter of concern for me, though. This is it's an annual performance report, and I really do think the full IGB should have sight of it. Has this been raised with the Scottish Government in terms of timing? I'm really concerned about this.
Well, in fact, we have the answer from Dave and Christine. Dave.
Yeah, no, absolutely. Again, understand that the frustrations there, Dorothy, because it is something that we are frustrated with ourselves in terms of, as Lindsay's described, there's a very short window to kind of pull this information together. We'll have to wait on information to be completed, verified, checked before we can include them. As much pre-work is done as possible to kind of facilitate the a lot more of the sort of stories and case studies, etc., kind of gathered earlier. It's more the actual stats, etc., but it is kind of pushing it really to the wire. The challenge is it's a legislative kind of deadline that's been put in place, so it's actually set in the legislation, which I think at the time there was a bit of a concern that from across the country that was very challenging kind of timescale to put in place. So we have got that situation. Even I think in the past we previously did hold a performance and audit committee meeting in July. I think we had a couple of years for that. The issue, of course, is it's in council recess as well. So that, and obviously it's the middle of the holiday period too. So, but again, even then, it was kind of pretty close to the wire for Lindsay and the team to be able to get the report completed in time for that. So, if we're looking at our schedule, in the June IGB is far too early because, in effect, the papers need to be produced a couple of weeks before that. And therefore, that's where we've been in this kind of hybrid kind of situation in the past. I mean, we can take it away and look to see if there's anything sort of a further way that we can try and do this. But I think we've kind of looked at different options in the past around how we might do it. But the fact it's right in the kind of middle of the recess doesn't help us with that as well. So, but we can have another kind of rethink in terms of how we might want to do it in the future.
Thanks, Dave. Christine, and then Catherine.
Yeah, thank you. I was just going to highlight that, yeah, given that really tight timescales that we've got, Lindsay, or via Arlene, we do actually issue a draft version to all IGB and PAC members, and that was actually issued on the 11th of July to all members, asking for comments and feedback, which I'm not sure if anything was provided back to Lindsay, but that opportunity was given off table to all members back in July, before the final version was then shared with the senior, the chair, vice chair, myself, Dave, and Roger Many for that formal governance sign off before it was actually submitted. So we know that the times are really tight. The governance process and timescales is not ideal, but there is the opportunity for PAC and IGB members to review it and comment on it before the final version does get submitted. So I don't know if that gives any sort of additional assurance as well.
Yeah, and thanks very much, Christine. And Catherine, finally, before I wind this one up.
Just to pick up the point about conversation and feedback to the Scottish Government, we have indeed fed back on that. There's other issues around the an annual performance report. The deadline, the statutory deadline, for example, is in advance of some of the information which we've got a statutory obligation to include actually being available from Public Health Scotland, for example. So it is a really tricky interaction of dates, and we have raised it and we will continue to raise it as part of the kind of social care reform conversations around how we move to a more effective and realistic approach to annual performance reporting. So just to reassure you, we'll continue to discuss that in the forums we've got available to us, Dorothy.
Thanks very much indeed, Catherine. And I think, Dorothy, the point's well laid, and I think we just have to further encourage the Chief Officer and colleagues to actually elevate this up to government to raise the issue of how can we possibly scrutinise an annual report, a performance report properly under the current situation. So I agree with you entirely, but that's the situation that we have. That doesn't mean to say that we can't make comment on the performance report. As Christine has alluded to, there's at least an opportunity to do that in draft form, as well as again at the formal sign off with the IJV albeit after July. That's the best we can do. And Dorothy, one final point, because I really want to move on.
If my concerns could be noted, that would be fine. I have actually another query on this report relating to 4.1.4 on, I think it's page 20. Which talks about the report should be to evidence to the public in an open, transparent and accessible way the use and impact of public resources. And I would really like to ask, how is this report made accessible to the public? I know it's online and can be looked at online. Is that all there is?
I'm kind of asking myself, was this question not asked at the IJV? I have a funny feeling. But anyway, who wants to respond to that before I must move on after this? Catherine.
Yep, thanks. We will provide paper copies in advance. We also share it across all our service providers, commissioned services in particular, and encourage them to make it available within services to Dorothy. I think the annual report is also made up of a number of contributions from different areas, and there's other ways in which a large number of those projects that are included in that have been presented to and discussed with and contributed to by members of the public too. But as a single report, I completely agree. Again, I think it's some of the limitations of the guidance that we have to follow nationally in terms of the requirements of the report, and that Lindsay has really worked really hard to make it and its current restrictions and what we must do as accessible as we can do as a single report. But I think that's another area that we've been raising with the government in terms of is this really the best way to present information to the public, and it may suit to have a composite report from an organisational point of view, but it doesn't necessarily suit to do that from an individual member of the public point of view as well. So I take your point around accessibility, but that's what we're able to do at the moment in the system that we have.
And thanks very much indeed. And I think, Dave, just to say is that there's a lot of good stuff in the performance report as well. This is that's well worth saying here, and maybe we need to have a chat on offline about how we can sell what we're actually doing here, because that's really what this is about, and there's a lot of good news in this too, so let's not forget that. Thank you very much indeed, and thank you for your comments, Dorothy, and they will be limited. That now takes me on to item 6, Dundee Health and Social Care Partnership Performance Report. That's 24-25, quarter 4. And again, Christine, you're going to lead on this.
Yeah, I think Shahida will speak to this report.
Thank you.
Yeah, so the purpose of this report is to give key information on the performance national indicators, the MSG indicators, and the social work demand data. So most of the indicators are rolling years, so that's from April 2024 to March 2025. And we have been comparing to 2 baseline years, 2018-19 and 2019-20. And that's because the end of 2020, well, March 2020 was the pandemic. So the duty under the legislation is to compare to the last 5 years. For the key messages in the data, it's worth noting that there are variations and inequalities amongst the 8 LTPP areas in Dundee. So for rate of emergency admissions per 100,000 aged 18 plus, this has increased in comparison to both of the baseline years. So increases are noted in all the LTP areas, and the largest increase was in the Ferry. There has been an improvement in the emergency bed day rate per 100,000 with decreases against both the baseline years. So this is a positive trend. Dundee ranked 10th in Scotland for this indicator, and we were the top performers against the family group. The 28-day readmission rate per 1,000 population has increased by 1% in comparisons to both baseline years. East End and Lochee both showed an improvement compared to both of the baseline years. So hospital admission rate due to a fall for over 65s increased by 5% when compared to both baseline years. Coldside and West End showed a decrease against both baseline years. Delays discharge for standard delays shows an improvement against both the baseline years, indicating an improvement. All the LTPP areas showed an improvement, so that's positive. For Code 9 delays, the performance was worse against the 2019-20 baseline year, but improved against the 2018-19 baseline year. Lochee and North East both showed an improvement against both the baseline years. So for social care demand data, the number of people waiting for social care assessments remains relatively steady, but the number of people waiting for a care package and hours still to be provided is just showing a small increase. Other updates, so the proportion of 6 months of life spent at home or in community settings shows an improvement at approximately 91%, with Dundee ranking 7th in Scotland and top of its family group. And there has been an increase in the proportion of people with intensive care needs receiving care at home, rising to over 65%. There has also been an improvement in proportion of care services graded good or better in care inspector inspections. So the most recent figure shows 83% with a good or better grading. Any questions?
And thank you very much, and thank you very much for this very detailed report. Dorothy.
Thank you, and thank you for that update. I actually had a number of questions on this, but considering the agenda, I will just raise the two that have jumped out at me most. Number 11, premature mortality rate. We're 30th out of 31 in Scotland, 7th out of 8 in the family group, and 3rd out of 3 in the Tayside group. And we're relying on 2023's latest published data. So a wee question, when are we likely to get updated data on this? That's my first question.
We'll
Do you want
find
to deal
out.
with that first question first? Then sorry, Lindsay, I interrupted.
Yeah.
Just answer that
Yeah.
question. Lindsay, just answer that question.
Thank you. Sorry, Sheila, you were going to come in there and I put my hand up.
Yeah.
But yes, we have been asking repeatedly for an update on that data. We realise it's not great. We really want to know our position. Everyone's interested in our position, particularly around that measure, but the data is not available from the government and there is no sign of when it will be either. But we do raise that at every opportunity.
Thanks, Lindsay, and thanks, Sheila. My other question relates to number 16, I think it is, 16 falls.
Is that, what's the page on that one, Dorothy?
122 is the big number at the top of the table.
That's grand. Thank you.
Hospital admissions due to falls rate per 1,000 for the 65 plus population. We're the worst in Scotland, the worst in the family group, and the worst in the Tayside group. That is a huge concern to me. And I think we have discussed this previously, and I just wonder whether we need to have a closer look into why our performance in Dundee is so bad on this.
Are you going to pick that one up, Lindsay?
Yes, please, I could start. I noticed that Matthew has put his camera on as well, but we're absolutely aware, and there's a falls data group which is looking closely at this, and we have been looking at it for some time. We think the pattern, the pathway of care is a little bit different in Dundee than elsewhere. We don't have a minor injuries unit, for instance, and we have looked closely at the data, and we have identified that there's a high proportion of people in Dundee who are admitted to hospital for a very short time and discharged back home quite quickly. So we've been looking to try and identify the proportion of those admissions that were social admissions as opposed to people admitted for a medical reason. So we feel that in Dundee that we're very good at caring, observing, hydrating, and we know that there's a lot of people in Dundee, a lot of our older population who live on their own up a flight of stairs. So we're mindful of that. So we think that it's partly good practice. So we're looking closely at the data. So we know that there's a large proportion of people who are admitted and discharged with no procedure, as I've said. But what we need to try and find out in there is that you can be coded for no procedure even if you get an X-ray. So actually, we want to try and separate out the people who we think could possibly have been looked after if there was a service in the community, and those who really needed to be in hospital. But Matthew's going to come in and tell you about what the plans are about changing service models, I'm sure. So I'll pass over to Matthew.
Thanks, Matthew.
Yeah, we're just in the last stages of putting together a day of care audit with our ED colleagues, really to have a look at the clinical journey through ED. The data doesn't tell us the whole picture, and we can't draw out all the information that we need. So we're wanting to actually look at patient journeys through ED to understand why they went there, why they stayed in, and where they were admitted to, etc. And as Linda's outlined, we think it will probably show us, because some of the early work supported this, that we're actually providing a high level of care for these patients. We're taking them in and we're making them safe. We're then returning them home with care wrapped around them to support them in a better way. I asked for a report from our Public Health Scotland colleagues recently, and the figures in Angus and Perth are deteriorating sort of rapidly as well. And I think as they use the 9 Wells ED more, the model that Lindsay described in terms of taking people in and caring for them and looking after them is having an impact within their figures as well. They'll be included within that day of care audit. We're also exploring far better use in the community of getting our services to intervene with people that have had a fall much earlier. So our Scottish Ambulance Service colleagues report something really quite simple. People fall, they're uninjured, but they can't get up off the floor. They will be a very low priority for the Scottish Ambulance Service because they have to respond to heart attacks and other things that need immediate attention. When they get to them, they've been laid on the floor for more than 6 hours, and the protocol is they have to go to the ED department. So what we want to try and put into place is a mechanism whereby those patients can be referred to our enhanced community support teams in the community, including physiotherapists, occupational therapists, dietitians, nurses, etc., so that we can assess the patients in the community, and if they indeed are uninjured, we will be able to help them off the floor and start the care immediately. They won't need to be conveyed to hospital. They won't need all of the care that's into there. So there's a lot of work to look at this, and we're very nearly there with completing it. I appreciate it's taken a very long time. It's quite a complex system, but as Lindsay said, I think it's possibly a measure of higher quality care, but we will get the data to substantiate that for you.
This is a fascinating subject area you raised here, Dorothy, and because clearly we're talking about almost like social falls as opposed to medical ongoing treatment, and that's a really interesting one in terms of the preventive agenda. Dave, have you any thoughts on this before I move on?
No, I think there's, as Lindsay and Matthew have described, we have been kind of looking at this. We have got a kind of a group wrapped around this to try and see what we can. To me, it's about, you know, just that better understanding from that group around, you know, the impact of the model, the fact that we are potentially different from other parts of the country. I think not having a minor injuries unit within the city does kind of then give some of our figures make a bit skewed because it is a straight to 9 Wells approach. So I think we'll continue to kind of report back anything from that group as appropriate to kind of see how that can change the shape of this in years to come.
And thanks for that, Dave. And it's also inside note that this is not just unique to Dundee City. This is also reflected in other IJV areas across Tayside as well. So,
Bob, can I just say I'm reassured by what I've heard. I suspected that it was an issue of good practice in Dundee. As an older person who fell outside a community centre one day and was taken to A&E, I have to say I was so well looked after. I didn't need anything at A&E, but the ambulance service were very, very caring, and I think because of my demographic, took particular care of me that day. So if it's good practice, that's great. But it's just the numbers don't really reflect that. They say, you know, there's a problem here. It's probably not a problem. It's probably that we're doing the right thing. Thank you.
Okay, thank you for that. And I note, Dorothy, you had a number of other questions as well, so I'm grateful for. But if you do want to, and Dorothy, you said you had a number of other questions, do you want to write into Dave and Christine with those questions that you're unable to ask today?
I will. I normally do that in advance of the meeting, but I've had a horrendously busy week, so I'll do it after the meeting. Happy to do that, Bob. Thank you.
Right, grateful. Thank you for that. So therefore, do we note the recommendations within the report? Yes, we do. And then we now move on to the item 7, which is Dundee Health and Social Care Partnership Clinical Care and Professional Governance Assurance Report, and that's on page 133 of the main papers.
I'll speak to this, Bob, if that's okay.
Thank you.
So the Clinical Care Professional Governance Report is presented today for a level of reasonable assurance, and that's what we'll be asking the committee to approve. I'll just give sort of high-level information from the report and then open to questions because of the size of the agenda. So the key issues really through this report are relating to increasing demand across a fairly wide number of services. The clinical and management capacity across some services is starting to impact on the ability to deliver the quality that they would like to. That's also having an impact, particularly within our drug and alcohol recovery services and mental health and LD services, on their ability to manage the adverse events, particularly in relation to morbidity and mortality reviews and the associated work with those. And the third area is in and around environmental risks, relatively low risks in terms of the scoring for the risks, but an increasing number of ongoing risks linked to the fabric of the buildings that we deliver care from. On page 143, the adverse events highlights a spike in May 2025. And we can see from that graph that the figures stay relatively static throughout the year with one dip sort of earlier in the year. And I suppose I'm really just raising this as part of the assurance mechanisms we've got in place in terms of understanding what happens with our adverse events and the level of intelligence we've got. That spike was almost exclusively down to feed issues relating to our nutrition and dietetic service and the provision of all nutritional supplements in the community. That was linked to a national shortage, but also to changes in the contract. Those adverse events now have all but ceased. So all of the work that has been done internally has managed that really well. Both the DDARS and mental health services have raised new risks in relation to their own capacity to meet the demands, particularly around adverse events, as I mentioned earlier. And I just wanted to sort of reference the quality improvement section, which does have just a few examples of some of the higher quality that some services are providing, but also the improvement work that teams are undertaking as well. And it's worth noting that with the increased demand, the pressures on staff, that they're still making the time, which is really important for their own learning, their own development, and the development of services as well. So that's all I want to say. I'll pause there for questions.
Thank you very much, and thank you very much for a very detailed report. Questions, please, Dorothy.
Bob, does your voice dip when you say my name? Because I've always got questions, sorry. Right,
I don't want
page.
To know you don't. I don't think that would work somehow.
No, that was my mother. 141, the clinical and care governance arrangements. First of all, thank you, Matthew, for that update. Thank you. Clinical and care exception reporting, which is B2 table, I think. My eye is drawn to psychology, where there's been no report and no speaker for psychology since December 2024. I can probably guess what you're going to tell me here, but I'd still like to hear it, if I may. Thank you.
Yeah, absolutely. Yeah, thank you for raising that. I mean, that has been raised internally for us at the group, and we've raised that through the management structure as well. Psychology have gone through an exceptionally challenging time with the inability to appoint to both a deputy director and a director. We've got Linda Graham, who's the acting director. She is currently going through a phased retirement and will be leaving us. We have appointed to a director post. I believe they start on the 8th of December, and a deputy director post has now been permanently appointed to as well. Now, while that says no right the way through that, and that is correct, Linda Graham has been attending these meetings and has been able to provide us with a verbal update, but it's not recorded in there because it wasn't somebody from the psychology service per se. So for the most urgent psychology issues, we have had a link through that meeting, and we have had the primary governance groups going ahead to provide a degree of assurance coming from there. But that is something that we are aware of, and we have put measures in place to ensure that changes moving forwards. Oh, I see Linda's popped onto the screen there as well.
Thank you, Matthew.
Linda, did you want to add to that?
I did, and thanks Matthew for that account. So there's been a changeover in the Deputy Director who chairs the primary governance group. So the only additional assurance that I can give is that whilst there have been no exception reports to R2, the primary governance group, it has still been meeting. So it's not that there's been no governance exercised in, it's that the assurance hasn't been provided up the way, and I add my apologies to those given by Matthew to that.
Thank you.
Further questions? I think we should always acknowledge within this report the discharge without delay work, which is exemplar, I would say, in Scottish terms, never mind just in Tayside terms. I think we should just acknowledge where we excel. And in terms of the new current risks we're added to the system, could you just expand a wee bit more on those two areas, please, Matthew?
Oh, just trying to.
That's an A3, which is page 144 electronic.
Sorry, what paper, Bob? Sorry, I'm struggling to find that.
It's page 144 of electronic, and it's A3, new current risks.
Yes. Okay. So the first one was in relation to some adverse events and some reported incidences of the quality of care not reaching the professional standard that we would expect within that team. They were highlighted to our lead nurse very quickly, and they commissioned a review of care within that team. That review has now been completed, and we've started to see a significant increase in the quality of care, the quality of nursing assessments being undertaken, but the action plan hasn't been formally signed off through our governance group yet, but that will come to the next one. So that was a good example, I suppose, of identifying practice that had fallen below the standard that we expected, and a very rapid response to address that and to put measures in place to support people to do that. The second one is in relation to the Patient Assessment Liaison Mental Health Service, which is a service that's delivered in our primary care mental health services. And that's really in relation to, they're looking to expand that into other GP practices across the city, but they're not able to find rooms to house all of the services. And if they can't find the rooms, they can't deliver the service from those GP practices. So they are in the process of trying to identify other ways of delivering that, or identifying rooms for that to be delivered.
And would you anticipate that issue about finding space is a short-term issue?
I think it's a fairly significant issue for us across the partnership. I think space is tight, and we do struggle to find space when we need it to deliver new areas, particularly in primary care. I think part of the sustainability in primary care work specifically highlights that accommodation across the primary care infrastructure is a challenge, but they're doing significant work to try and develop that independently as well.
Okay, thank you. And I think we'll note that when we're looking at the assurance report to the IJV. And I would have thought that the medicine for elderly ones should be relatively short term, given the good news that you've provided in terms of improved service. So yes, that's really helpful. Thank you so much indeed. I see Angela come in.
Thanks, Bob. It was just to assure that, yes, there has been some really clear signs of improvement, and that has been sustained over a number of weeks. So really positive, and that risk should be closed down again fairly quickly.
Thank you. Okay, no further questions. Can we therefore accept the recommendations within the report? Thank you. It's 11 o'clock. Can we take a 5-minute break, and then we'll come back, okay? Thank you very much indeed. Thank you, everyone. We'll now move on to item number 8, which is the Mental Health Services Indicators, Q4. Who's leading on this today?
Yeah, Shahida's going to initially present, and then Linda Graham's going to come in and with any further information.
Thanks, Christine.
Okay, so the purpose of this report is to update the Performance and Audit Committee and the suite of measures relating to the activity of mental health services. So I'll give a summary of the data. So for the number of all mental health admissions for the 18 to 64 age groups, there was a slight decrease, and for the 65 plus age group, there was a slight increase. The rate per 1,000 admissions for all mental health admissions decreased slightly for the 18 to 64 age group and was the highest in Lockheed and Coldside. For the 65 plus age group, it was the highest in East End and the lowest in Strathmartin. For emergency admissions for mental health, again, there was a slight decline for the 18 to 64 age group and a gradual increase for the 65 plus age group. The rate per 1,000 emergency admissions for mental health for the 18 to 64 age group showed that Lockheed had the highest rate and the Ferry had the lowest. And for the 65 plus age group, East End had the highest and Strathmartin had the lowest. Looking at bed days for mental health, there has been a decrease for both the general mental health admissions and the emergency admissions. This is for the 18 to 64 age group and 65 plus. The 18 to 64 age group had the highest rate of bed days per 1,000, and that was the highest in Lockheed and North East. So comparing this to our family group, Dundee had the second highest rate after Glasgow. For the 65 plus age group, the highest rate of bed days per 1,000 population was the highest rate was in East End and the lowest was in Strathmartin. Comparing this to the family group, Dundee was fourth out of the 8 partnerships for the 65 plus age group. So delayed discharges for the mental health specialities showed a downward trend across all categories, included standard delays, Code 9 delays, another reason. However, the percentage of delayed discharge bed days attributed to mental health specialities show an upward trend for standard delays and a downward trend for Code 9 delays, another reason. For psychological therapies, following an increasing trend, numbers now seem to be declining slightly, and approximately 2/3 commenced the treatment within 18 weeks. The highest number of referrals were from Strathmartin. There has been a steady increase in the number of referrals to the CMA, the community mental health teams. This was just over 60% was accepted at Q4, and there's been a notable drop in the number of people discharged without being seen. There has been the referrals to the psychiatry of old age have been relatively steady, as well as the number of referrals that are accepted. Just over 60% were accepted. There has been a steady increase in the number of referrals to learning disabilities. The highest number of referrals are from the West End, and there has been an increasing trend in the number of people discharged without being seen. For social care data, there has been an increase in the mental health referrals and guardianship applications. Any questions?
There's quite a lot to digest in this report. And who wants to start asking questions on this one? Dorothy.
Thank you. I'll restrict myself to 2 and a wee suggestion, if I may. Could the table of the indicators and the updates be numbered in future? Because that would be really useful in terms of me, getting through it. One thing in the report that I focused on was at 5.6, and that's in page 154 is the big number at the top, about the number of children on the Child Protection Register. Now, I understand this report's about mental health, is focused on mental health, and so this relates to children whose placement on the register was linked to their carers' mental health. But I wondered, I would really be interested to see if there's any information on the longer term trend for the number of children placed on the Child Protection Register. it may not be relevant to this report, but if someone could direct me to where I could find that information, that would be useful. That's my first question.
Catherine, do you want to pick that one up before Dorothy asks her next question?
Yeah, we've got lots of data about that, Dorothy, and we can provide that off table to you.
Thank you so much, Catherine. You're a font of information. Thank you. My second question relates to the number of people discharged without being seen, which is steadily increasing. I just wonder, could someone tell me what is this suggesting to us, or is it so complex that it's suggesting a number of things? But what is that? What should we take from that? Should we be concerned?
Linda?
Dorothy, if you can live with a degree of speculation in my answer, I think the association is with the length of time that people are waiting to be seen. And what we know is that you get spontaneous remission for a significant number of cases by doing nothing. So by way of illustration, that's actually where the psychological therapy's 18-week referral to treatment target came from in the first instance, was that if you waited 18 weeks, there were lots of people got better without any direct intervention. So that's not a reason why we would be happy with waiting times. But I think it probably is to do with that. We have people waiting really significant amounts of time. On a positive note, the hope would be that they've navigated to other intensities of care, be that digital therapies or third sector supports, and no longer need our intervention. What I can assure about is we're pretty assertive in trying to get a hold of people. So we almost don't take advantage of the fact that we try and appoint people and they don't respond to us. You know, the booking rules encourage us towards making more than one attempt to get a hold of people. And if that's a particularly complex profile, we will be assertively chasing people, but that sometimes doesn't bear any fruit.
I was going to ask, if I may, just off the back of Dorothy's question, is that if we have a number of people who are referred and then because of the time it would take for them to be seen, what information is provided that gives them the guidance to look at alternative approaches or other agencies, Linda, at the point of referral?
Thank you. There's a substandard patient leaflet goes out, and the letter that acknowledges referral into the system contains details of where help can be kind of accessed whilst waiting, additional to contact details for how to respond if they feel their conditions worsening, and access to our duty worker system.
So in other words, we're not doing nothing, we're actually still providing guidance. Yeah.
Correct.
Okay, thank you. Dorothy, have any further questions on this?
I'll email them, Bob.
Oh, thank you. I was going to pick up on 7.2 on the improvement plan, and I was just reading the narrative on it in 7.1 and 7.2. That's on pages 155, 156. I wasn't quite sure how to take this in, really. There's some key lines in it. You're talking about realistic recruitment plan and extra investment, which doesn't seem to be there. It's not currently affordable, and small increase in resource. I wasn't quite sure where we were going with this, and what level of assurance we would have from that. So I'm just a bit perplexed about this one. Linda, do you want to go in that specific one, and then I'll ring in Dorothy?
Before Linda, before you respond, can I? This was one of the other things that I wanted to ask about, and what concerned me most was that no additional resource accompanied the sort of special measures that, you know, that really concerned me, and I don't know if anybody could comment on that. Thanks.
I can, and I will. Oh, Dave, do you want to come in?
No, Linda, you go
I
first.
think Linda, you go
Okay.
first, and then I'll bring in Dave. Thank you.
I'll go first, and if I'm talking for too long, colleagues, tell me to hold my wheesht.
You've got plenty of time, Linda, don't worry.
So the best way to think about psychological therapies is that referral to treatment target, where they ask for 90% of the population to be seen within 18 weeks of referral. The figure that you see as having a slight decline in it is aggregated across a range of different specialties. And the easiest way to think about it is that we've got 18 different specialties which contribute to that target. 9 of them are actually completely meeting the target on a consistent basis. There are a further 3 who are sitting in the 80 to 90% bracket who we think will get over the line. But we have 6 areas of interest which are of kind of particular sort of interest to us. And those tend to be the higher volume services. So our adult services that sit in adult psychological therapies, sometimes described as primary care psychology, and our psychology that sits within the CMHT. There's also been pockets around clinical health psychology, and our biggest issue is with clinical neuropsychology, which has been to do with low staffing levels. So partnership has already put in a small increase in posts. So we appointed 2.6 master's level posts in the summer, and we have just on Friday closed the recruitment process for our doctorate level staff, and I'm pleased to say that of the 10 posts that we have out to advert, we have 18 shortlistable candidates, which is exceptional for us. Normally we struggle to appoint to those doctoral level posts. So with the modest investment that's there, and if we recruit to these posts, then at the moment what we're expecting to happen is that of the 6 who are not meeting the target, 3 of them will. 1 by November 2025, so very quickly, 1 by March 2026, and 1 by June 2026. So what has happened, given that we think there is still a shortfall in the staffing levels that we would need, particularly in terms of clinical neuropsychology, which is the very difficult to recruit to sort of specialty, is that we have an additional paper going to Performance and Resource Committee, which I suspect is why Dave's looking to come in behind me.
And is that the anticipatory question, Dave?
Yeah, absolutely. Well set up by Linda there. So yeah, so thanks for that, Linda. So yeah, this because it's obviously it's an NHS signed kind of provided service, and it's under enhanced report. We have been asked to, Linda and I have been asked to bring a report into through NHS side around for assurance around the measures that are being taken to kind of improve our performance around this. Much of what of that is around what Linda's already described, in addition to some of the kind of changes in service provision that have been made over the last kind of year to kind of help to improve our performance around that. I think the kind of £1.5 million that's noted down there is really this is what it would take in terms of additional investment for us to kind of move straight to and kind of everything meeting the performance targets that's there, but it's not an ask of such of a resource. It's really about this is the sort of scale that would be required. Now, given the financial situation that we are in across the whole of Tayside, there needs to be a kind of discussion around that sort of if that's something that we would want to prioritise in terms of a resource, or how we can manage that in the future anyway. So Linda and I are working on a further detailed report just now for NHS Tayside. and I'm sure we can bring something back on this to the Performance and Audit Committee in due course. Thanks.
Thanks, Dave. Colleen.
Mine was just a really quick comment to say thank you for that kind of detailed description of what exactly is going on there, because as we're all aware that there's vacancy issues there. It's fantastic to hear the progress that's happening there under really tight financial restraints that we have, and delighted to hear that there's 18 potentially appointable candidates for the 10 posts. That's really going to make a huge difference. So thank you for all the hard work, really, is all I wanted to say.
And thanks very much indeed. Are there any further questions on this paper? Okay. Therefore, can we note the recommendations within the paper? And we'll now move on to the next item, which is the Drug and Alcohol Services Indicator, Q4 report, item 9.
I think that's me again. Right, so I'll give a summary of the Drugs and Alcohol Performance Report. So the number of suspected non-fatal overdose incidents reported by the Scottish Ambulance Service and the Police Scotland has increased slightly, rising from 192 in Q4 23-24 to 206 in Q4 24-25. The waiting time standard is 90% of all patients to begin their treatment within 21 days of being reformed. So performance on this has been consistent in the past year, ranging from 89% to 93%, and standards have been met in the past 2 quarters. There has been modest increases in the number of referrals to alcohol treatment in the past few quarters, and for drug treatment there has been a slight decrease in the past few quarters. There has been a decrease in the number of alcohol brief interventions. The number of unplanned discharges or where the service user disengaged has decreased by 20% between Q4 23-24 and Q4 24-25. So the rate per 1,000 population for emergency admissions, where the reason for admissions was drug use, was 2.4 per 1,000 population at Q4. So the highest rate was in Maryfield and the lowest was in the Ferry. And the rate per 1,000 population for emergency admission where the reason was due to alcohol use was 3.5 per 1,000 population, with Lockheed having the highest rate and North East having the lowest. And any questions?
Dorothy?
It's not really a question. It's a comment on 7.6, which is on page 183. Dundee Recovery Network is developing involvement from those with lived experience. I'm so happy to hear this, contributing to the LCPP and working with local communities. I would be grateful for some, I don't mean today, but I would be grateful for some additional information around this. I think this is definitely the way to go. I'm happy to see it appearing in the report, and maybe at some time in the future, some additional information could be provided perhaps to the IJB on how this works and how well it's working. Thank you.
Okay, we'll note that, Dorothy, thank you. I have a question round about non-fatal overdoses, and do we have any data that relates to non-fatal overdoses to those who have actually have led to real suicides? Catherine?
Thanks, Bob. I think it might be better for Lindsay to go first because she's probably got some detail I might not have.
No, I actually don't. I was actually just going to say we will take that back and get that will be available, but I don't have the data to hand.
Yeah, it's just the question for me is it's the follow-up from such incidences, and particularly given that suicide prevention is such a major issue for us in Dundee, it's a question I'd just like to see what is the follow-up when we know there are definitely vulnerable people at risk. And Catherine, do you want to come back in on that?
Yeah, as Lindsay says, we can take it off table. I think that we will probably have linked data between people who we've become aware of in terms of a near fatal overdose and then drug-related deaths. I don't think we will have linked data with suicides. Yeah, there's obviously quite a complex interaction between drug overdose and suicide and understanding the intention of the person as well, and whether there was any intent in terms of suicide sitting behind a drug-related death as well. So it's quite a complex area in terms it's not just a straightforward matching of data and an assumption that one is correlating with the other. So we can take that back and ask the question. Bob, I'll be interested to see what's been considered about that previously.
Okay, thank you for that. Are there any further questions on this paper then, and to note the recommendations? I don't see any. Thank you very much indeed. That then takes us on to item 10, unscheduled care. That's on page 199.
Stuff. Thank you very much. It's back to me. So delayed discharge, that continues to be rigorously monitored on a daily basis through daily and weekly management reporting and oversight reporting. So the current position against the national indicators, the national indicator is the days people over 75 spend in hospital when they're ready to be discharged at a rate per 1,000 of the population. So that is sitting as very good. We're actually performing the third best in Scotland based on the 2024-25 performance. That's an annual figure that we get. And it sits just behind Angus. Looking at across Tayside, Angus was actually the second best performing. Pepper and Kinross was the 9th best performing. So as a Tayside board, we're doing very good. But as everything is, sort of the devil is within the detail. And when you look at different age groups and different levels of complexity that sit underneath that. So when we look closer at the data, we know that there is variation in the average duration of delays for under 75s compared with over 75. So it's sitting at an average of 46 days lost for the under 75s and 14 days lost for the over 75. So this isn't new to you. This is the same sort of narrative that you receive regularly, but this is reflecting the complexity with the younger adult inpatient population around general adults, psychiatry and learning disabilities. Although we have noted that due to the socio-demographics in Dundee, we know that that the population is getting sort of multi-morbidities, long-term conditions with complexities around drug and alcohol use, for instance, and mental health at a younger age than elsewhere in the country, particularly associated with deprivation. So we are seeing delays in sort of the younger age group in sort of the sort of general acute wards in Ninewells as well. So we know that there's correlation between the bed days lost and social care unmet need. So where the unmet need goes up, bed days lost goes up as well. So over the last quarter, the bed days lost has increased as a result of that, sitting at 44 bed days lost on the snapshot date of the 11th of August 2025. Although when you look at it over time, you see actually that it is an overall improvement. So when we look back at April 2023, the bed days lost was actually sitting at 604. So it is an overall improvement, although we have seen a recent spike in bed days lost. So it's often helpful, and it was mentioned earlier in the in the meeting to look at bed days lost in the context of all discharges. So we're sitting at 99%, which is positive. So we have key actions reported in the paper that include the expansion of the Dundee Enhanced Community, the DECAT team, Dundee Enhanced, oh goodness, it's gone out of my head what it stands for, in the evening and over a 7-day period to reduce hospital admissions, to improve community support. Further work with the Medicine for the Elderly medical team, which is now working in more alignment with GP clusters, focusing on polypharmacy and virtual wards. Continued focused on early intervention prevention, particularly working with GP clusters around that. Royal Victoria Hospital improvement plan is in place to reduce the longest stays in medicine for the elderly wards, and step down bed model in stroke and neuro pathways, which are focusing on whole systems. We have recruited additional inpatient frailty advanced nurse practitioners to support the whole system patient flow, and we are stepping up again the discharge to assess model for social care with the aim of minimising care home admissions, and finally the redesign of the AHP services across whole system patient pathways as well. I'm sure that Angie will be able to come in with any sort of further operational updates if I've missed anything.
Well, we'll see what happens there. Further to any questions, please? Dorothy?
Just a comment. It's a good, positive report with improvement showing, and I'm so glad to see it. And well done to everybody who's been involved in this work. Thank you.
Yeah, it is a very positive report, and it's not lost in a sort of third best in Scotland. I think one of the things is the crunch point for me is when you look at the section 3 on financial implications, and basically what we're really saying in this is that this isn't financially sustainable. So how are we going to deal with this issue? Because we know that we're regularly monitoring budgets here. How long can we continue to keep up this level of performance, and what is acceptable to the IJV? I'm going to take Christine first, and then I'll take Angie.
Thank you. Absolutely, you're correct. The trajectory and the direction of travel in terms of supporting people who are medically well enough to return home, and also and making sure that the right pathways of care are in there, is absolutely the right thing that we should be doing. And obviously that's clearly a national direction as well. But it is very clearly recognised in terms of our own financial plan and our cost pressures that we're sitting with, that we do not have enough resources to sustain the current levels of activity and the current pathways and the current levels of demand. But we are working whole system with our own management team and with wider with NHS Tayside colleagues and across Tayside, and highlighting back to sort of Scottish Government. How do we, this is what we want to be doing, this is the right thing to be doing, but we need to be managing this within the resources that we have, and making sure that everything that we are doing is working as efficiently, effectively. We're maximising the capacity that we have within the resources that we have. But it is the biggest financial challenge that we have just now, is sustaining this level and everything else that we're currently delivering as well. So it's that's our biggest risk in terms of that. There is some additional money from Scottish Government this year in terms of unscheduled care pathways that was distributed nationally. Unfortunately, the amount of money that we got was nowhere near the original bid that we submitted, but we are using that money to sustain and try to maximise what we can deliver with it. But I'll let Angie come in as well.
Angie.
Thank you. Yeah, there is a number of initiatives that we are continuing to work with. So the original exercise has reduced the overall number of hours by 1,000 without having any direct impact on service users receiving those services, in terms of we're not cutting service or anything like that. There is reviews ongoing, because there are still a number of people who have a service who maybe don't need as much as they have at the moment, and pressures across the system mean that reviews have not been carried out, so we're focusing on that at the moment to do the next level. We're also looking at tech solutions, so looking at how do we make sure that the assessments are as accurate as possible by using technology within the home to inform that assessment. When is the right time to put a service in so we're not wasting services, that kind of thing. We're also looking at, as Christine says, whole system. So if social care can provide the medication administration, that frees up services elsewhere in the system to get the overall budget kept in a line, but making best use of resources. So a lot of that's still ongoing. We're not quite at the end of that process yet, but the wins from that are getting smaller.
I think that's really helpful, Angie, because I think the IJV itself needs to see more of the detail of this when we come to looking at the actuality of the how we're addressing the sustainability issue. And certainly that's something we would highlight in the assurance report to the IJV itself, that about the concrete measures we're actually taking, but also just acknowledging the ultimate limitations to that, as you've just suggested in your final statement there, because there does come a line when we have to say what is it we cannot continue to do, and I think that's where the crunch issue for the IJV comes when we next look at the budgets. Thank you so much for this. There's a lot of good work here, I know that, but this is a real risk to the finances of the organisation. So I just want to note that. Thank you. Are there any other questions on unscheduled care? Okay, thank you very much indeed. We note the recommendations, and I think the complexity of this issue and how we're trying to respond to these pressures are going to be absolutely key to what we do moving ahead here, because we're only, what is this, so far within the financial year. So where we'll be towards the end of the year in this year, it strikes me as something that we really need to look at very closely. Thank you very much indeed. That now takes me on to item 11, the care inspectorate gradings, and I finally found a list from Christine. Catherine, you're leading on this.
Yeah, I'll just very briefly introduce this because it's an annual report, so members, I'm sure, will be familiar with it. There's not been any significant changes to the inspection regime in terms of kind of method or content or focus this year. There were 53 inspections across 44 registered services, and almost exactly a 50-50 split between care homes and then other adult services in Dundee. From a care home perspective, there has been a positive increase in gradings, including a greater proportion moving from the good category into very good and excellent, although there is one a provider that's noted as having an evaluation of unsatisfactory, and there's further detail in the appendix to the report around the support provided there. For other adult services, the grading profiles remained pretty stable. There's not been any significant change. And just to point out, in terms of health and social care internal services, there was particularly strong performance this year, including one service, White Top, where there was excellence across the board, which is not an easy thing to achieve. So, as I say, the appendix has further significant detail around the kind of improvement support, including support for 3 care homes where there were poor gradings at the end of the year. I did a quick check yesterday, and just to say 2 of those have been re-inspected since the end of the financial year, and there's been a significant movement in their gradings, with the majority now sitting in good, or in fact in some cases very good, a couple of adequate still in amongst that, and they're continuing to work on it, but there's been a big shift for 2 of the providers. One continues to work and has recently had a new manager appointed, so there's a lot of focus on being able to work with a new management team to move on the position in that final home. And the only thing left to say is my apologies, at page 221 there is a section highlighted in yellow around drug and alcohol improvement areas and content, which we missed when we were doing the final papers to be filled in. So we will make sure that information is circulated out with the meeting. That was entirely my fault and not Rosie's. Thank you.
Thank you. Now, we appreciate the workload pressures at the moment, understand that. Questions for Catherine? I think we note that there's quite a lot of improvements that are indicated in this report, and your later update just further confirms that. I suppose one of the questions for me is, what influence do we have on care providers, or private care providers, in fact, as an HSCP to advance these improvements?
I mean, Angie might want to comment as well. Yeah, I think we do have a significant amount of influence through partnership working. I mean, obviously, through our contractual relationships with providers, that is a kind of key element. But I think we've described to the IGB before that our relationship is built on a kind of partnership and collaboration rather than us always relying on contractual terms, although we will do that if we get in a position where we need to. But I think there is really good close working between the Care Inspectorate, Social Care Contracts team, operational leads and providers, where there are poor inspection gradings, I suppose. And I think there's a lot of cooperation around improvements, and even things like looking at voluntary suspension of placements, etc., where that is normally a mutual agreement with the provider as well, to be able to kind of pause things and help with improvement support. And you see that in terms of, you know, when I looked at the gradings yesterday for a couple of the care homes where things have moved on, their gradings haven't just come up a wee bit and sitting at adequate. Actually, they've really improved quite significantly. So I think we do have quite a lot of influence and quite a role to play there. So Angie will have further comment.
Thank you, that's helpful. Angie?
Thank you. Yeah, just to add to what Catherine said, because of that mutual sort of partnership arrangement that we've had in Dundee for a long time, through the partnership for the Providers Forum and through the contractual arrangements, we also have the care home team, which was set up probably about 2 decades ago now, and was quite unique in the way that we provided support. So that's a combination of social work and health staff who go in and support alongside the management of the services. They can provide advice, guidance, training. There's a whole host of work that they do. So there's a lot of good supports there, and because of that partnership working, most of the providers are really, really happy to have that support coming in. There's also a lot of sharing of documents, ways of working, good practice. So everybody's always learning from each other as well.
Mm-hmm. Thank you. Yes, I'm just reflecting on when we commission services and looking at the detail of each of these different arrangements, and it's about are we absolutely sure that we're getting best value for our investment, as one put it that way, into these services? Maybe that's a broader question I might tease out at another time. Thank you very much indeed. I don't see any further questions on this, and I'm therefore going to move on to the Strategic Risk Register update. Catherine.
Yep, thanks, Bob. Again, I'll keep this brief. So they're slightly different to the normal risk register update. So a bit of a tale of two halves. So just the first part of the report is just confirming that there has been no changes to the IGP Strategic Risk Register since it was last reported in May. 6 risks are high risks and 4 at the maximum level, and it's appended for members' information. I think we thought it was an important opportunity just to formalise and bring to the board some of the conversations that we've had with you in development sessions around the intention to do a more thorough update of the Strategic Risk Register, which I know a number of members have indicated they're very supportive of, and that work is underway, and we hope to complete it by the end of this year. I guess the risk register has kind of developed and evolved over a number of years, but I think we felt that at this point in time it would be helpful to take a bit more of a substantive step back and think about both its content and the infrastructure that sits around about it. So as described in 5.2, we'll be having a look at the content and its relevance and making sure there's a clear focus on the strategic risks that relate to the IGB's functions. We've also obviously recently agreed risk appetite and new risk categories that are reflected in the paper, so we'll get those implemented both into the format of further risk register, but also the reporting arrangements around it. And there are some other changes we want to make around the reporting arrangements, format, escalation of risk, those sorts of things that relate to some of the outstanding actions in the governance action plan, which obviously come on to later in the meeting. So it was really just to bring it here in a formal way and to make sure that it's noted that that work is ongoing and that we expect to complete it by the end of this year.
Yeah, great. And we note that favour will come to the IJV in December. Okay, and thank you for that. Any questions for Catherine? Okay, thank you very much indeed, Catherine. That then takes us to VEST value arrangements and assessment. Christine.
Yep, thank you. So again, another annual report to PAC in terms of providing assurance that the IGB, as a collective IGB, we are meeting the best value requirements as set out in legislation. So we do have legal and statutory duties to achieve and deliver best value, and that best value criteria is defined as that continuous improvement in performance of the organisation's functions through using public resources wisely. The appendix that's attached to the report provides a list on an assessment of all the various actions and the evidence that we've collated in terms of confirming and that best value is being achieved. And the report highlights the IGB's governance achievements, arrangements, support, continuous improvement and effective service delivery. The assessment is structured around 7 key themes: vision and leadership, governance and accountability, effective use of resources, partnership and collaborative working with communities, sustainable development and fairness and equality. So it takes into account all the different aspects of our sort of governance and communication and accountability that we need to be looking at collectively across the year. So happy to pick up any questions that anybody has, but this is for noting and provision of assurance.
And thank you, Christine. It's a very helpful report, this, in fact. Dorothy.
Thank you, and thank you, Christine. I have a request for more information on theme 1, number 1, where it tells us that the IGB's vision is developed in partnership with its citizens, employees, key partners and other stakeholders. And the evidence says that local strategies are led by strategic planning groups, which comprise of people who use services. How does that actually work? Do people who use services sit on these strategic planning groups? How do they feed in their views?
Yeah, so we do have a number of sort of localised strategic planning groups. One of the probably some of the most active ones is the mental health, but we do have other strategic planning groups out there, and then we have an overarching strategic planning advisory group, which pulls in partners from various different aspects of it. I saw Catherine's hand going up and going back down. Catherine, was there anything else that you wanted to highlight in terms of?
No, I was just going to say, Christine, is a bit of a mix, Dorothy, between some groups who have direct representation on the group and have had that as a long-standing thing. Learning disability, mental health and carers are particularly strong around that. Others use other ways of involving and engaging wider public or service user groups, particularly through third sector services. I think that interface through the third sector, particularly in terms of involvement and engagement, is a key kind of skill set of theirs and resource.
Thank you. I think I'm just looking for some reassurance that we have some confidence that we are working with our citizens and service users. Can I be reassured of that? Yes?
Yes. Again, Dorothy, I think it's potentially stronger in some areas than others, and we're looking at how we spread some of that best practice. But we've been looking at that in terms of writing some of our materials for the mental health inspection that's ongoing, and that's a particular area of strength there. So I think how that plays out looks slightly different in different areas, but that's probably appropriate given the complexity of people's needs and different service user groups and what suits them best as well. Everything can always be better, so I think there's bits where we could strengthen it, but I do think there's a real culture and commitment to involvement and engagement.
Thank you.
No, I think the point's well made, Dorothy, and of course that just adds further leverage into our own board, in fact, with having a service user representative, which we don't have at the moment. So I dare say that will be as work in progress, but it's something that's becoming quite urgent. And I know that there have been various conversations with Health and Social Care in Scotland around these matters in relation to that area, and indeed in carers too, for that matter. So thank you for that. No other questions. So I'm going to move on to the Governance Action Plan Progress Report. Catherine.
Sorry, I couldn't find buttons there. So the Governance Action Plan Progress Update, again, pretty standard report, so I'll just put out the highlights. There's 6 actions completed since the last report, but 11 new ones added on. I dare say the gap is like painting the 4th bridge. As soon as you get something off, you have to start again with the new ones. So those are the internal audit annual report actions from 24-25 that were agreed recently. We also at that point had realised that we had forgotten to add on the ones from 23-24, so we've taken the ones that were marked as outstanding by the auditors in the 24-25 report and also added the amendments. So that's the 11 new ones in there. There's been some level of progress in around half of the 23 ongoing actions. Biggest kind of areas of movement this time round have been around the work that Christine's been leading around savings and transformation and getting more routine and more detailed reporting to the board, but also internally in our budget delivery group around about that. The progress we made around working with IGB on risk appetite, and also the progress we made when we completed the kind of workforce planning our kind of delivery plan round about that and had that approved recently. So there's some chunky bits that have moved on. Similarly, in the next 6 months, we would probably expect to see a number of actions that are grouped around aspects to do with the strategic plan, which will be moved on through the review of the strategic plan that's ongoing at the moment, and ones that are grouped around the risk register that I referred to earlier. So I'd hope by the time we're towards the end of the financial year, we'll get a few more moved on, because we'll be able to incorporate those actions into those pieces of work. As usual, happy to take questions, or others will be, who are responsible for actions on the detailed appendix that's attached to the report.
Questions, Dorothy?
I don't have a specific question. It's more a sort of general overview. There are a number of really old, overdue actions here. 1 from 2020, 2 from 2021, 7 from 2022, 5 from 2023, and 6 from 2024. Now, do we need to have a discussion around whether some of these remain relevant? I'm trying to cut down your work here. I'm not saying that it's not important that these actions are actioned, but could we maybe have not me specifically, but is it time to have a look at some of these long overdue ones and make a decision as to whether they should remain as outstanding actions, or whether they've been superseded by things that have come since?
Catherine?
Yeah, we did previously make some recommendations when we reinstated reporting around the gap to abandon some actions for that reason, Dorothy. So happy to go back and have another look at that, and obviously discuss that with Christine and internal audit colleagues as well, if there's anything further we can do. I think some of them are also might be slightly different recommendations, but the solution and the action is the same action. So, when we do some of the work around the risk register, that may tick off, quite a number of actions, and the recommendations or findings from an audit perspective So I think it's some of that's that complexity about the finding or the recommendation might be slightly different, but the solution's the same one as well. So, but again, obviously Christine and I can go away and have a look at that, with keeping your comments in mind, and see if there's any further streamlining we can do. We would also welcome that, obviously. So we can take that as an action and have a look.
Thanks for that, Catherine. And of course, we're moving on to a couple of audit favours. So perhaps we might ask that question there about how that is dealt with internal audit as well. Thank you. Are there any other questions for this before I move on to the next favour? No, that's fine. And that means we now move on to item 15, which is Dundee Integration Joint Board Internal Audit Plan 24-25. And Christine, I believe you and Vary are leading on this.
Yeah, thank you. So I'll just briefly introduce it and then give Barry the chance to come in with any further comments it needs to highlight. So this is a progress report on the 24-25 internal audit plan, and also update on some of the shared relevant audit findings from partner organisations that might impact on the IJB. So the appendix that you've got had 5 particular actions or audits on it. 1 to 4 are all fully complete, and the field work is currently ongoing for the final piece of work, which is on lead partner services, with that report currently anticipated in November. And section 4.5 highlights that reasonable assurance has been provided on an NHS Tayside audit on their annual report. And also highlights reasonable assurance on 2 audits on behalf of Dundee City Council, 1 on risk management and 1 on payroll change of circumstances. Barry, is there anything that you particularly want to highlight from the report?
There's nothing more specific from the report, but I just want to say that we are continuing to sort of take forward our improvement work following the recent external quality assessment and our mapping to the global internal audit standards. And one of the items that's falling out of that is, and it'll be reported to the next committee, is we'll be presenting our updated internal audit charter. So it's really just to give you a feel that, you know, we are progressing our improvement plan. It's been monitored through the health board and what's called our partnership board, who are responsible for our internal audit consortium. I have nothing else to add from what Christine said to the progress report.
Okay, that then, thank you very much. That then takes us to the internal audit plan 25-26.
Okay, thank you. And I'll just quickly introduce this one as well. So this is the plan for the coming financial, or the current financial year that we're in, 25-26. And also that this is submitted for approval from PAC. And also PAC has also asked to agree the continued improvement of FTF and the Chief Internal Auditor arrangements for the coming year. It's proposed that FTF continue as lead internal auditors, with the plan being then jointly delivered through NHS Tayside, Dundee City Council internal audit teams. The plan allocates 40 audit days, 20 from each of the 2 teams to cover all that required audit work. The audit plan is risk-based and designed to provide assurance to the adequacy and effectiveness of internal controls, governance and risk management to PAC, and then onward assurance up to IJB. And details of the work plan are provided in the appendix for that. So this is for approval for both the plan and the appointment of Chief Internal Auditor. Barry, is there anything that you need to specifically highlight?
Just want to sort of highlight the work we do on the internal control evaluation. Our plan is to definitely get that work undertaken early in 2026, and we'll be reporting our findings by March 2026. And we appreciate we've delivered that product a little bit later in the year recently, but you know, we will do it to that timetable, and it'll certainly help sort of minimise demands on officers at the year-end period. I don't really have anything else to highlight. Again, Christine's stolen my thunder.
Sorry.
Oh well. And are there any questions before I move to the recommendations for agreement on the recommendations? No, silence is golden in this case. So there are two recommendations are asked to agree, and that is about the continuation of Fife, Tayside and Forth Valley Audit Internal Audit as the ITV's lead internal auditors, and the continuing Chief Internal Auditor arrangement for 25-26. Do we approve that? And also approve the 25-26 annual internal audit plan as set out in Appendix 1. Do we approve? The answer is yes. Thank you very much for that. And Christine, how frequently do you meet with the internal auditors to talk offline through various issues that arise? I'm curious.
We don't have a scheduled sort of set of report or conversations in there. It is very much as and when pieces of the work plan are coming together or there's particular queries with it. Through sort of the January, February, March and April time when the internal control evaluation work is ongoing, we do have a lot more conversations at that particular point, and just an updates in terms of the progress plan. So it's ad hoc, but it is reasonably regular as and when workloads and particular pieces of work are needing to be progressed.
Thanks very much for that. I'd quite value joining you for one of those informal meetings, just to get the tenor of the nature of the discussions, if that would be advisable. Before the end of the year would be helpful before you move into the intensive work period in January, February, March. But I'd quite appreciate that. It gives me a chance to speak informally to both you and Barry. If you could just let me know when that is, I'd quite happy to join you.
Yeah, I'll have a chat with Jocelyn and Barry, and we and sometime perhaps at our early stage of the internal control evaluation, start that process.
That would
might
be really
a good
helpful.
time.
Thank you. I'd appreciate that. Thank you. Okay. The item 17 is the attendance list that is there for your information, and the date of the next meeting will be held on the 19th of November. Hopefully with a slightly less challenging agenda this time. Thank you so much for your attendance today. I've managed to just keep it into the 2 hours. So thanks very much indeed. And thank you for your attendance today. Thank you so much indeed and your contributions.
Thank you.
Thank you.